This is Physio Matters in association with Choose Health, and this is session 5. Hello and welcome back to Physio Natters. This month I've had the great pleasure of talking to Steven A Woor. I wanted to get Steven A Woor onto Physio Natters for a while to discuss red flags, and conveniently we had an excellent podcast with Karen Middleton of the CSP in which she discussed self-referral, and I thought these two things went hand in hand. As such, I've had the opportunity to ask Steve a few questions and gain his thoughts. I'll see you at the end. Right, that looks like we're all good.
Rocking?
I think we are rocking, and we're about the same level, which is quite nice. Oh, right, oh God, where's my stuff? Right. At least this will make it easy for me to edit, because it's already in the editing program. Right, so what I'll do a little bit of an introduction for us, and then the first thing I've got on here is red flag screening. So if we... I wasn't necessarily going to go through specific red flags for a specific...
I think just a general chat around...
Exactly. We'd be here all week if we went through every single one.
Oh, we could be, yeah, I think it's just the context of it, isn't it, more than anything else?
Exactly. And then just a little bit about what we think general knowledge of red flags is like in physio, and then relate that to direct access.
Yeah.
Happy with that?
Sounds good to me.
Brilliant. Right, okie doke, here we go. Hello and welcome back to Physio Natters. I'm here with Steve Nawoor. How are you doing, Steve, this evening?
All good, thank you. You all right?
Excellent. Yeah, I'm very good, thanks. We've had a bit of technical problems, but I think we're there. I've got a bit of a strange setup on my end, but hopefully it'll work nicely. Just give us a little bit of an overview of you, Steve. Where do you come from? What are you up to at the moment?
Well, I'm currently an ESP in the NHS. My background from before physio in the army doing mines and demolitions, into the prison service as a PTI, and trained as a physio last 4 years while in prison still. And then I went into the NHS, lots of rotations, worked up through different roles, senior 2, into different NHS trusts, a bit of private practice, bit of elite sport, bit of travel, professional, bit of Nuffield Health for a while. And then ESP in the NHS, closer to home now, in Stoke-on-Trent.
Brilliant. You've been around a bit then, haven't you?
Thanks for that, Jack.
No, that's all right. Now, one of the reasons that I wanted to get you on here, talk a bit about red flags, was we were at Therapy Expo last year, and you gave a brilliant talk, and I can't remember quite which way round it was, because John Doyle was there and gave an equally good talk. And I can't remember whether you spoke first or he spoke first, but anyway, they both were really good. And I thought I'd pick your brains about red flags, context, all that kind of thing, and see if we can come to some sort of conclusion as to where we're at with these kind of things, because it's not easy to do in clinic.
Yeah, no, I agree. I mean, I think, last year, John and mine, there was a little bit of overlap with some of our work. We knew what what each person was presenting. I kind of went down more of the masqueraders route, and John was more about sensitivity and specificity. I mean, if we were going to debate red flags, we would be here all night. It's, I think it's more about setting the context of, for the physio, and the different levels that we're working at, I suppose, and what we're taught at undergrad, and how we maybe put that into clinical practice, and some of the debate around flags at the moment, and what is out there and what is sensitive, what's not. It's a very difficult situation for an undergrad coming into the profession, I think, as well as it is for even ESPs or consultant physios working in clinic that are being challenged every day with complex patients.
Yeah, I was going to say, I find it hard enough.
Yeah, every day, today we had a full clinic, and there's a number of things there where you've got to, set the context for, is that, first thing I always ask myself, really, I suppose, is that patient appropriate for myself? And, if they're not, who needs to see that patient, or what do I need to do with them at that particular point in time? And that might not be the fact that I've gone through an algorithm in my head about particular flags. It might be intuition, clinical intuition versus clinical assessment sometimes, and sometimes that comes with patient mileage and being able to pattern recognition and having a vigilance and awareness of red flags. But we know that some of them, in the primary care setting, between 1% and 5% of all patients who present with back pain, that's a serious spinal pathology is going to fall within that parameter. So, having information around that is good, but I think where we weight the flags is very critical sometimes. And I think what we're taught probably along those lines is, every single tick box that we go through, do we then have to investigate? Do we have to, are we sending that patient to A&E, or what do we do with that patient? I think setting the context around those flags is really key.
Yeah, definitely. I think one thing that I've heard recently, which is helpful, is one, we don't rule out the red flags, we stay vigilant to them, but also sometimes it's keeping an eye. You might have someone, you've got a little bit of a thought, this person doesn't look that well, but actually their symptoms seem relatively correlated with some sort of normal-ish musculoskeletal disorder, but then two sort of sessions down the line, you're going, well, actually, this isn't reacting how I thought it might be, and then those inklings that you had in the first instance might then be brought more to the fore, and it's not about necessarily, like you say, on that first contact. I mean, it might be if you only got one contact, but if it's on the first contact and you don't necessarily do something about it right at that point, but then you make sure that you keep that in the back of your mind as you go forwards. Is that sort of fair?
Yeah, I think index of suspicion is probably the terminology that most people are, au fait with. And I think, depending on what setting you're working in, there's an expectation that, like you say, I think rightly, if you've got only one or two contacts with a particular patient, you're probably having to work a lot harder as to the decision you're going to make sometimes. But that doesn't mean that if you're dictating a letter appropriately to another professional that, you don't raise those markers as if there is a change in that patient's status, that you're aware of some of the symptoms potentially. But I think, vigilance at the beginning is fine, but you don't always have to make a decision unless you've got an accumulation of flags that are absolutely critical to the next steps for that particular patient.
Yeah. Are there any flags or any symptoms, Steve, where you say that is a definite onward referral out of physio department? Is there anything that you would say definitively you would go for that, or?
I mean, I think the ones that jump to mind are going to be, obviously some of the flavoursome ones would be where you've got a cauda equina potentially. But I mean, even then, some of the debate that's around that now, and some of the new statistics that have come from some of the research, we're still in an area there where that is going to be a lot of it on the subjective assessment. And, again, it's not a barn door that patient's going to go, but there's this whole situation now, even with CES, about suspected CES, so do we come to a point where we would do something automatically there? I'm not sure I would sometimes, and I have actually, maybe that's a phone call to, depending on your pathway, to the spinal team, say, look, I've got a patient with me, you explain the symptoms, and, you come up with a joint decision there. And many a time I've spoke to the spinal team in Derby and we've said, at this particular time, guys, it's not appropriate to send them in, let's do a watch and wait. And that's okay to do that sometimes, but it's having that support network around you sometimes to make those decisions. We can't always make that decision in isolation, I think.
A bit of bouncing ideas off another person sometimes is helpful.
Definitely. And even if we're thinking, I think everyone jumps to the forefront, and we're looking at making sure we don't miss a cancer or malignancy, and talking about that again in context is what are the flags that lead up to that? We know that some of the flags around someone being over the age of 50, not responding well to treatment, are not that sensitive anymore. One of the biggest ones for us now is going to be a previous history of cancer. So what do we do with that? Everyone that's got a previous history of cancer, are we looking to kind of manage that in a situation where we would move that on? We've got to step back and then think of that as a whole. The statistics are there for that, but that's at about 4.5%, I think, with a previous history of cancer. But there's over 200 cancers out there. The top 4 make over 53% of that. Right. So again, that's a context. I think we've got to step back and go, yes, some of the flags we've been taught in the past, there's an accumulation factor, but the biggest one out there at the moment is a previous history of cancer.
Yeah, that's great. Give me a couple of thoughts, Steve, on, I had a re-listen to one of the Physio Matters podcast from a while ago on hemodynamics with Alan Taylor, and he was talking about sort of some vascular disorders of the lower limb, for example. So if one of those came into clinic, you wouldn't necessarily get an overt red flag, but there would be signs, they're subtle signs, but certainly I would struggle to pick one up. And maybe not necessarily this is on the same level as missing a cancer, but what do you think about that sort of thing with symptoms, like you said, a cluster of symptoms that would suggest a condition which is relatively rare, but then that physios are unaware of or have a lack of knowledge of, so they're then proceeding to treat as a musculoskeletal condition. Do you think there's a fair chunk of that we're missing out on, or am I being paranoid?
Maybe a little bit paranoid sometimes, but I think, are you talking about really where we're looking at a neurogenic versus a vasculogenic, or where we're talking, you could be talking about where we're looking at a lumbar spinal stenosis sometimes, which some people, we can look at a neurogenic versus a vasculogenic picture with that from a perspective. So some of the signs and symptoms that might come with a stenotic pattern sometimes, some of the questions that would come around that might lead us to go, well, how do we differentiate between somebody that's a stenotic pattern that's got pain in certain positions versus, is that a stenotic pattern, or is that, have we got a claudication picture? So, some of the questions that we might ask, there's so much overlap between them, I think. So if you're talking about someone that, let's say, for example, gets heavy legs with walking, but they rest and then that goes, what does that mean to us? And then they can go again for a certain period of time, or is there some other vascular subjective factors that they come out with which you link together? There has been an increase in shortness of breath recently, there has been increased fatigue. The only positions of rest are when they sit down for particular periods, or with vascular claudication and some of the upper limb or the lower limb symptoms, it's just trying to make sure that we're not, I don't think we have to be so definitive to say it's this or that. It's just going, well, actually, if that's a vascular disorder, what factors make that up? And if it was a stenotic pattern, what factors make that up? And, the crossover between them is quite high. So I think it's difficult to sometimes make a decision in clinic. Obviously, you'll be looking at, from a vascular assessment, you may be looking at your distal pulses, even just as an example. And, how many of us are competent in just even assessing those, I suppose, is a question.
Yeah. I mean, that takes a certain amount of that takes a certain amount of knowledge, doesn't it, to then ask those questions around. So if you've got someone, let's say you've got a 70-odd-year-old and they come in and they have got a stenotic pattern, my sort of usually my sort of assumption would be, well, they've got a stenotic pattern, not necessarily let's ask more vascular questions. Now, admittedly, since the hemodynamics podcast, I now ask the vascular questions because, like I say, I get a bit paranoid. But not everybody is necessarily going to do that, and I think we'll come on to it later. But when we're talking about direct access, we all almost need to be not paranoid, because it's a ridiculous thing to be, but aware of the different conditions, and I'm not certain that everybody is at that same awareness.
Yeah, I just think it's a lot of it goes back to even if we're talking about let's take that vascular presentation, for example. A lot of that should come up from its understanding, I suppose, the subjective past medical history, even if there's is there a family history of PVD, peripheral vascular disease, and how much do we weigh that to some of the other things that they're talking, they're a heavy smoker, some other bits and pieces which might come into that.
Yeah. And
maybe, yes, the less experience might just brush over the subjective, but then when you match that with some of your objective testing and some of their concerns around general exercise tolerance, whether that's walking in the garden or walking a mile around the shops. But I think you're right, maybe the ability to delve a bit deeper into questions is maybe the more experienced practitioner potentially, but there's definitely grey area within that, I think, and for any of us, for the experienced ones through to new grads.
Yeah, that is definitely true. Okay, let's move on to sort of talking a bit more about what we do when we suspect that red flags might be present, or we want to do something about red flags. Have you got any advice? Let's say we've got a new grad in clinic and they sort of go, well, I'm pretty sure that this is a medical problem, not a physio problem. What would you suggest that they do? Is there any advice you'd go there?
first and foremost, is the pathways that they have in place from a governance perspective. So, every practice, every service should have pathways that are appropriately set up, competency frameworks that support that. That if something arises that the physio isn't aware, isn't happy with from a medical perspective, they're not sure what's going on, they should be able to either knock on the door of a colleague, speak to the GP, speak to another allied health professional to get that advice. So the pathways and the clinical pathways and the governance structure around that is understanding that, so when you're in that situation, what's your first call.
Brilliant. Yeah.
It's not even making a clinical decision. You shouldn't be if you're not sure what's going on, as we all are on days, the first port of call is to step back from the situation and make sure that you get the right answer or the right pathway for that person next. So it's about patient safety, not taking a chance that I think I'm going to leave this person and move them on. I think you've got to be really clear on what your pathway is, how that's set up, and the support structure that there's to govern that.
Yeah. Okay, that's great. How about what would you sort of say about addressing the conversation after that with the patient? So it's difficult enough for me in rheumatology when I go, I think you've got ankylosing spondylitis. Never mind, I think you've got, X, Y, and Z that could be dangerous to your health. I mean, obviously we don't want to go scaring the living daylights out of the patients, but equally we don't want to be negating the fact that this could be serious. Have you got any advice on broaching that conversation?
Yeah, I mean, I think when you get to the point in normally the subjective history, really, there should be a point in time where you're either making a decision to go down one of two paths. One is I'm going to continue, and two is I'm not. And I think when I get to that stage where I'm thinking, this isn't MSK, the MSK hat comes off, and generally how I approach the patient is say, that's really good, that information that you've given me there. I'm just going to take you down a slightly different path with some different questions, if that's all right. And then I just nearly confirm what I think I need to get from that before I then either step back and ask a colleague or think about how I'm going to present that information back to the patient. I think for maybe if you're working at a certain level, you're more used to having that conversation. I wouldn't expect someone to have a conversation about some kind of serious pathology, even if it's a hypothesis at that stage. I think that is more to say, I've got the information, I just need to go and discuss a few bits with a colleague, and you come back to them, or you come back to them with a colleague or a senior that's going to be able to help you deliver whatever message you need to.
Yeah. So you wouldn't, obviously we wouldn't go mentioning specific diagnoses, because then, people grab onto that. So would you sort of say something along the lines of, I think we need to investigate this further. I'm going to refer you over to, either if you've got direct access to, wherever, rheumatology, oncology, wherever that ability is, going to refer you over there for an opinion? Or would you sort of go more via the GP to broach that conversation? I mean, some people will have to go back to the GP, won't they? But what would you sort of say? How would you say that? Almost ending the consultation. How would you go about that?
You're always thinking about how you're going to wrap up that conversation so the patient knows exactly what's happening next. They have to be really clear. So I think the key thing is for that is to go, whatever your findings are, I think it's more about saying, you've got two routes. It's either I've got all the information I need now and I don't want to make a decision on what we're doing next until I've spoke to a colleague. That's fine to come back to the patient. As long as you're going to say, I will give you a call, or I will speak to you, or there's going to be a communication afterwards if you're leaving it a little bit door open. I think that is, whichever way, you have to be transparent to say, I just need to check a few pieces before I come back to you. That's fine to do that. The other piece is just to say, I just need to speak to the colleague, like I said, and you might need to speak to the GP, and it might be someone else that needs to deliver a message of some sort at that stage. But I wouldn't be delivering any bad information, because I don't think that's our call to do that. In most circumstances, I think that's about the appropriate professional delivering that. I think more and more when we're in first contact roles, obviously there's a different question there, and some of us are already in there where we are having that conversation, as you will do in rheumatology, as I will in an ESP clinic. But that's not for everyone, I think, and I think that not everyone is where they've got to have that structure where they can drop into that and have a clear pathways to how they deliver a message.
Yeah, so you're happy leaving the conversation open as long as you've got an end point to that open conversation. So we're going to go and I'm going to find a bit more information from some other colleagues, and I will contact you with what the plan will be. Yeah.
I mean, it might be something as simple as, I'm thinking I want to do an MR arthrogram for a shoulder.
Yeah.
And, in a particular service, I might have to have that signed off by another colleague. So, in that respect, I'm saying this is what I think we need to do with you. However, what I just need to do, I just need to run this past someone before we do that. If there's any changes, I'll come back to you. But, you leave it in a position where they're really clear that what you're doing is this. You might need to get some confirmation before you actually organise that, but you just need to be really clear with the patient as to what the message is going to be.
Brilliant, that's great. Okay, you mentioned sort of direct access, which is brilliant because somewhere where I wanted to go. What are your thoughts on widespread direct access? So obviously we had Karen Middleton on the podcast recently talking about the aim of being completely direct access, which I think is a brilliant idea. Again, maybe it's my paranoia coming in, but all musculoskeletal conditions that are seen by GPs coming into a physio department, have you got sort of any concerns like I do with regards to red flag screening and complex condition screening? Have you got any thoughts on that for me?
Yeah, I mean, direct access, I mean, it's where the profession is going is absolutely amazing, I think, and the opportunity that comes with some of the things that are happening is great. I think, if you're looking back at direct access, some of the things, the main benefits they're trying to do is improve the clinical outcomes, reduction in waiting times, improve patient choice, reduce costs, and workload on GPs. But, I think some of the things we've got to be careful about, one of my concerns, as probably one of yours is just, does direct access mean that any condition can end up on the doorstep of a band 5, for example, in a GP practice with no support? And I think, that's probably worst case scenario for me, whereas, they're in an isolated practice where they're receiving anything that comes through the door and maybe not having the appropriate setup to help support that. So my concern is, I suppose, that, we ensure that as part of this rollout that we have, clear structures in place from a national perspective through to regional variants to allow us to support an isolated practice, people that have access to a GP, people that have access to ESPs. There's so many different healthcare models out there, but I do worry slightly that, if once the doors are open, it's just making sure that we can, I think, support the staff and make sure patients are safe within those environments. And it's working well in Scotland. There's it's been there. It's already up and running. And from all the statistics and information that's coming back, there are no issues. But I think we are now, dipping our toe into the water now, aren't we? Where, we could have what I'd class as potentially inexperienced physios having self-referral, which within the NHS setting, we're dealing with a lot more complex patients, I feel, or you could have, patients which we're presented with much more long-term conditions and more comorbidities that we need to be able to manage. And I know we've talked about some of them today, but we're just touching the surface there. And it's not to say that you have to have an ESP seeing every single patient that comes through at all. I think all we're saying is that the structure has to be there to support that individual physio if the patient in front of them or the person in front of them is not appropriate for them to see and they're not sure what to do.
Yeah, I think the governance is a real good point, and I think when Jack was talking to Karen about it, he was obviously saying if direct access was to come in tomorrow, would we be able to cope? And I think probably the correct answer is no, we wouldn't. But given a time to put those correct sort of governance things into place, then I think that we could well cope. I mean, his quote that I'll pick him up on was, "We're going to miss a hell of a lot of cancer." And then Karen's response was, "Well, band 5s tend to be more vigilant about red flags than anybody else." And then that's how it goes to me. Well, either what's going to happen is we're going to miss a hell of a lot of cancer, or we're going to annoy the crap out of GPs because we're going to be sending all these patients back going, "I'm worried about this patient, and actually there's nothing wrong with them." And then
the hypervigilance is one thing, isn't it? I think, and obviously physios come out of university and are armed with that information. I think, if we flip that and you've got a new grad in practice and they have a person that they're concerned about, we're trying to reduce contact time, but what we might end up having, this is just hypothetical, is having a physio that is always relying on the GP for advice and direction. So, a self-referral into let's say a band 5 in a practice, they haven't got any capability to do anything with that patient, bar treat them really to an extent, or make a decision where they'd like to send them for x-ray, or they think they need something else as further workup. If they do require further workup, obviously, they're either asking the GP or what is the pathway for that particular process. So it's just making sure that, I suppose, anything end up on the doorstep, if that's what we're understanding, and how is that managed to make sure that, number one, they've got the competency to deal with that. Have we got a band 5 sitting in a practice that hasn't done any form of rotation within the NHS previously, and it hasn't been exposed to a number of pathologies across their first year, 18 months, 2 years. So there's lots of questions there, and you could flip that again on a number of different levels, really. I just think the self-referral is great. I just feel that we need to ensure that each region, on a national perspective, we've got appropriate competency frameworks to support that. Advanced practice document that's come from the CSB is fantastic, and that highlights lots of information there. But the big thing they mentioned there really is, it's a combination of advanced skills, knowledge, and attitudes that enables physios to address complex problems in unpredictable contexts. And that's advanced practice. Now I could extrapolate some of that and say, well, some of those patients that we've just mentioned within advanced practice is going to end up with a new grad. So they could end up with anything, but we might be stipulating that advanced practice is around, critical thinking, complex needs, safety, competency. So I think there's a crossover, but I think we've got to be really clear on the competency framework to support all of them and the governance that's going to underpin that.
Yeah, I think that's certainly the way we've got to go, really. I think that's definitely it, really, isn't it? I mean, getting those plans set in motion before things are rolled out.
Yeah, and I think, there's so many good examples of it everywhere, with Paula Deacon down at IPOPS, SSOTP, where I'm working now with Kay Stevenson. All of the frameworks are there in different guises. Neil Langridge's work, what the consultant physio group are doing. There's so many pockets of fantastic information out there. And I think it's just, and I know there's work going on behind the scenes now about how this is looking for the profession. So, I think it's there. It's just bringing it to the forefront to make sure that we're really clear as a profession as to how that's going to look with self-referral and how we're going to support the staff and make sure that patient have the best outcome.
That's brilliant. Well, let's hope all these things move forward, because like you say, I think self-referral is definitely the way forwards for physios. I think we can make it, one, a huge difference, but two, what a great stride forwards for autonomy and building the profession as general. Yeah,
it is. And I think, and I think Karen was kind of, she did hit the nail on the head actually about being, is there a difference between a first contact practitioner and someone that's getting self-referral? And I think there is, and I think it's just ironing out what that actually means.
Yeah, brilliant. Well, great. That's absolutely brilliant, Steve. I won't keep you from your sleep any longer. I know you've got IFOMP to go to next week, haven't you? Because you're away from the kids. You'll be partying non-stop, won't you?
Well, Jack Tuesday, so probably not.
Well, he's going to keep a rein on you.
No, that's great, Jack.
All right. Lovely to speak to you, Steve. All right. Thanks for chatting to me.
Okay.
Brilliant. Thanks.
Bye.
Well, there we go. Thank you very much to Steve for answering my questions. I think you'll all agree that's a very useful way of thinking about red flags and what we should do with them once we find them. Sometimes we should do nothing. Watch and wait is not a bad policy, and as such, I think Steve's point about discussing with colleagues is an excellent one. This does raise questions about lone working. However, with appropriate support systems in place, I think these things can be overcome, but we shouldn't be hasty. Please discuss this further over social media and get in contact if necessary. Steve is at Steve Nawoor. The Physio Matters team at TPM Podcast. And I am at Physio Jack. Don't forget to listen to all of our podcasts, including the Physio Matters and Physio Natters. We have recent bonus podcasts regarding cause health, and there will be more about this shortly regarding the entire presentations. We continue with many other projects, and I hope that you will also look up our Patreon feed, in which you can become a patron of our podcast and support us in an entirely new way. Thank you for listening, and I'll see you next time. Bye for now.